if a patient's first cycle is canceled, it's always difficult to know how to move forward, and we would like to guide their care to have a better outcome in their second cycle. It does happen, though, that they can have a second cycle that's canceled if there is advanced age, if there is a BMI of over 30, which is considered obese, if there's a diagnosis of diminished ovarian reserve, and some of those markers are a high FSH or a low AMH. If that was present in the first cycle and it's still true in the second cycle, they have a higher chance of cancellation. If they were canceled in the first cycle due to poor response. So all of these things together clinically are significant indicators and associations with increased cancellation in the second cycle. Adding to the bad news is a reduced chance of live birth in the second cycle. Again, advanced age, over 35. Hard to believe that's considered advanced age, but it is. A history of smoking. Actually, race, Asian and Black patients have increased risk of not having a live birth in the second cycle. And again, as you would expect, diminished ovarian reserve with the markers of high FSH and low AMH. So the good news is that if a patient does get a canceled cycle and they go through again, almost 76% of patients go through and don't get canceled. And live birth is positively associated in that second cycle with, interestingly, a diagnosis of male factor. And if their first cycle was canceled, not for poor response, but for any other reason, including inadequate endometrial response. What we found too in our data is that patients with a prior agonist or antagonist cycle that were canceled, they changed their stimulation to either the antagonist or agonist cycle in the second cycle, they had higher odds of live birth independent of egg yield. So thank you so much to Sheila and Nabil and all the organizers and sponsors of this meeting, these regional meetings. Now we have quite a few of them, and they're terrific for small group format and learning from leaders and sharing content and meeting people. I think it's really great, so I encourage you all to participate as much as you can. So the title of my talk, obviously, Cancel Culture, IVF Outcomes from Second Stimulation Cycles Following First Cycle Cancellation. And this was a topic I was given, and I really didn't know what I was going to talk about, and it turns out I actually have some original data to show you, which I'll share with you today. And this is my disclosure. So the learning objectives today are to predict, predictors of live birth or recurrent cycle cancellation in a cycle following an IVF cycle cancellation. So I'll describe all of that in a minute. Also to identify any modifiable factors which improve outcomes following IVF cycle cancellation, and any lab KPIs which are associated with improved outcomes, again, following a cancellation. Is there any way to get the notes? I feel like I'm going to okay, perfect, thank you. I'll just fake it till I make it here, okay. Oh, maybe I have notes here, terrific, let me see if I can do this. So this is a very simple schematic of how the process starts, and it starts, of course, with a physician consultation. They do testing for day 3 FSH, E2, they do antral follicle count, AMH. They work with the patient to develop the gonadotropin protocol and the dosing. And next, the injectables are given for controlled ovarian hyperstimulation for about an average of 11 days, followed by an ovulation trigger and egg retrieval about 36 hours later under ultrasound guidance. Eggs are retrieved, fertilized, embryos are transferred back into the patient during a fresh transfer, or actually very commonly are frozen for later transfer or biopsied and frozen for later transfer. So despite continued advancements in ART and the more or less personalized nature of each cycle, IVF cycles unfortunately do not always go as planned. In fact, about 10% of cycles per year are canceled during the stimulation process before even reaching the egg retrieval stage. By far, the most common reason for this is poor response to stimulation, but may also occur for over-response, inadequate endometrial response, something like a concurrent illness or withdrawal for personal or financial reasons. Oh, thank you, Nabil. I actually do see comments here, so yeah, I think it's okay. I think I can fake it. Okay, thanks. That's very kind, thank you. So when cycle cancellation occurs, patients must be counseled about their adjusted, predicted chance of a live birth if they were to repeat a cycle. So in these scenarios, REIs often look to alternative stimulation protocols as a more desired response, to achieve a more desired response. And this is really one of the only variables that we are able to modify from cycle to cycle. However, data supporting this is limited in that existing studies that either evaluate a second stimulation after a completed cycle, so it wasn't canceled, one that made it all the way to a transfer, or they don't look at the outcome of live birth. So I'd like to present some original research that we have done on this topic. My fellow Jenna Kahn, she completed this study actually as her thesis project, and she's graduating in another month. And we've submitted this paper for peer review to Fertility and Sterility. And we just got comments back this morning. So we are using SART data. This is a self-reported national IVF registry, SART cores, which everyone in this room knows about. And what we did was we sought to understand which patients are most likely to have a live birth from a second cycle after a cancellation, and to determine any possible predictive variables for cycle success. We also wanted to determine which patients were at risk for recurrent cycle cancellation. And finally, we wanted to determine if changing the STIM protocol in the next IVF cycle affected odds of live birth or recurrent cycle cancellation. So this was a retrospective cohort study of first IVF cycles from SART member clinics between 2014 and 2017. That resulted in a cancellation and was followed by a second IVF cycle within the same study period. So as you know, the SART cores database, it represents about 81% of all clinics and 95% of all cycles in the US. And each cycle is given a SART number at the initiation of the cycle, regardless of the outcome. And since 2014, we were able to link cycles, as you know, from their index cycle of stimulation all the way through to all their subsequent cycles, including FETs, to give you a cumulative live birth rate. And this is why we did this from 2014 to 2017. So data are collected through voluntary submission. It's verified by SART and reported to the CDC, and this is all in compliance with a federal mandate, the Fertility Clinic Success Rate and Certification Act. This is from 1992. The database is validated annually. It's a very rigorous process that SART leadership undergoes for the data. They do quality assurance and validation. I can talk about that in more detail after this talk. And generally, it's found that the data has a discrepancy rate of less than or equal to 5%. So in our study, we defined cycle cancellation as cycles which were stopped during stimulation before the egg retrieval. These are the inclusion criteria, and additional exclusion criteria were any supernumerary cycles that were canceled, meaning if someone did 4 cycles, but cycle 1 and 3 were canceled, only the first and the subsequent cycles were included in the study. We also excluded any fertility preservation cycles. These are some of the demographic variables that we controlled for: maternal age, obviously, BMI, race, which is not a very well-populated field, I'll admit, but the fellow had an interest in this specifically. Smoking status, also not well-populated. Gravidity, parity, and infertility diagnosis, these were all collected from the index IVF cycle. Cycle characteristics assessed were the day of cancellation, baseline FSH and AMH, and also the reason for the cycle cancellation of the index cycle. So a total of 13,340 index cycles were included and analyzed for both the demographic and the clinical predictors of their linked second IVF cycle outcomes. So these were the univariate analysis variables. There were 3,112 patients who had recurrent cycle cancellation and 10,228 egg retrievals. So most of them made it to retrieval after cancellation, half of which made it to embryo transfer, and there were 1,860 live births. So this figure shows the unadjusted probabilities of live birth and or recurrent cycle cancellation based on maternal age. So the x-axis is, I don't want to turn away. The x-axis is the SART age groups, and the y-axis is the percent of probability. So we know that maternal age is strongly associated with IVF outcomes. So this is just to show you that as the age of the patient increases, the chance of recurrent cancellation increases, and that's in blue, and the chances of live birth decreases, and that's in yellow. So you can see that women 43 years old and older have about a 40% chance of having their cycle canceled for a second time. And this is largely due to poor response to the stimulation. Interestingly, this entire population, the live birth we're seeing here, even in the younger patients, is about half of the age-predicted live birth rate as reported by IVF success calculators from both SART and CDC. So this whole population is considered, a diminished ovarian reserve population, not surprisingly. Okay, I'll take you through this figure. So this figure shows the result of our multivariate logistic regression for odds of recurrent cancellation. The pink dots, you can see them at the top, represent statistically significant results with p-value of less than 0.05. Confounders that we adjusted for are listed on the right. So the odds of recurrent cycle cancellation increased, okay? So patients who went through and then got canceled again were of higher maternal age, higher BMI, actually in the category known as obesity, a diagnosis of DOR with the clinical metrics that you would expect, a high FSH and a low AMH, less than or equal to 1.0 nanograms per ml, and the index cycle cancellation was due to poor ovarian stimulation. Those with PCOS or unexplained infertility and an index cycle cancellation or withdrawal from treatment due to concurrent illness had less chance of cancellation. Now, these are the odds of live birth. So this shows the multivariate logistic regression for odds of live birth. Again, the pink dots represent statistically significant results, and confounders we adjusted for are listed on the right. So again, live birth is associated, interesting, with a diagnosis of male factor and an index cycle cancellation indication of withdrawal from treatment for any other reason besides DOR. Odds of live birth, however, decreased in the second cycle if the maternal age was greater than or equal to 35, associated with smoking, Asian race, Black race, diagnosis of DOR, and again, a high FSH and a low AMH. So we did a sub-analysis to look at whether changing the protocol in the second cycle would impact their outcomes. But before I go into that, I just want to provide a little bit of a background on the 3 protocols that SART collects data for. So there's 3 of them. Let me go through this here. This is why I wanted my notes. So the agonist flare protocol utilizes an initial flare of the effect of the agonist to increase endogenous FSH, which is bolstered by the addition of exogenous gonadotropin, and the agonist also blocks an endogenous LH surge by prolonged saturation of the receptor. The suppression protocol starts in the luteal phase prior with the agonist to avoid the initial flare in the follicular phase, and this ultimately results in ovarian suppression, allowing complete control of follicular growth from exogenous gonadotropins, and it also blocks the endogenous LH surge by prolonged saturation of the receptor. And the last protocol, which is the most popular and most, I would say, used these days, is the antagonist protocol. It is using only exogenous gonadotropins to stimulate the ovaries, and once the follicular growth begins, the antagonist is added to prevent the LH surge until you are ready to trigger for ovulation. So again, these were the 3 protocols that were used: agonist flare, agonist suppression, and agonist. And we were measuring this in the first cycle, and in the second cycle, exclusive use of these protocols. We used the same inclusion-exclusion criteria as the initial analysis, and additionally excluded any cycles that had more than 1 STIM protocol listed, because that's not really possible. That must have been a self-reported error with the data. And after applying this new exclusion criteria, there were 13,135 patients in our population. So patients who received the same protocol compared to those who changed. So here we go. So we use regression models to estimate the association of changes with the odds of recurrence of cancellation or live birth. And again, we adjust it for age, race, BMI, smoking status, AMH, infertility diagnosis. All the cycles were included for the outcome of recurrent cancellation, and we did a sub-analysis of just fresh cycles, about 12,000 of them for live birth. And secondary outcomes were lab KPIs, number of eggs retrieved, and number of 2PNs. So there were 6,434 patients in the same protocol group and 6,701 patients in the change protocol group. The demographic characteristics were similar between two groups. 78% of all patients who had their first cycle canceled for poor response went through for the second cycle. So the mean AMH in the same protocol group was 1.49 compared to 0.98 in the change protocol group, and they both had increases in gonadotropin on the second cycle. This was definitely a confounder, so we did the analysis with and without that. There was no difference in the outcome. There was about 400 extra IUs that was given in the change protocol, in the second, stimulation protocol. This was significantly different. So after adjusting for confounders, we found that changing the protocol in the second cycle was associated with 0.36 less eggs retrieved and 0.29 fewer 2PNs created in the second cycle, which is statistically significant but not clinically significant. However, changing the protocol did show a 14% decrease in odds of recurrent cycle cancellation. So there's value in changing the protocol, and a 17% increase in odds of live birth increase, both of which were statistically significant. And this is a sub-analysis of the fresh cycles that were canceled for poor response. And again, change in protocol associated with a 20% decrease in cancellation and an 18% increase in odds of live birth. So which change matters? And this is the last part of my talk. We've done stratified the data by the index protocol type to further understand the drivers of our results. So this table, and I know it's complicated, but I'll go through it. This table depicts a regression model stratified by the type of protocol change, estimating the association of specific change protocols with odds of cancellation or odds of live birth, as well as number of eggs retrieved and the 2PNs. So, oh no, I'm not getting the animations. Oh dear. Okay, so let me try it here. So this is the agonist flare. Here we go. So compared with those who stayed on an agonist flare protocol, those who switched to a suppression had on average 3.25 more eggs retrieved and a 67% decreased odds of cycle cancellation. And this is the specific change that's driving the overall decrease in recurrent cancellation with a protocol change seen in the previous model. So changing to an antagonist protocol did not statistically improve or worsen the outcome, so it's switching away from the flare was the key. And conversely, compared to those who use an agonist or an antagonist in their first cycle, switching to an agonist was much worse. Basically, the flare was the problem. And I don't want to go through all of these. It's a lot of the same data, which is complicated. But the point is that changing the protocol has value. Changing away from the flare has value. And so to summarize, in patients with an agonist suppression or an antagonist cycle cancellation, changing their stim to the second protocol that alternates it results in a higher chance of live birth, independent of egg yield. Changing away from the flare increases your egg yield and decreases odds of cancellation, but doesn't affect the odds of live birth. So the strengths of this study include that it's a large population from the national data. It's very diverse. It speaks to the generalizability of the findings. To our knowledge, though, so this is the largest study that we know addressing the change in protocol and the outcomes of live birth or cancellation. And we actually did the sub-analysis of fresh cycles only to look at the impact on live birth. We've avoided the confounding impact of FETs. Because of that, we just looked at fresh cycles for live birth outcomes. The limitations, obviously, it's a retrospective study. This is always a limitation with SART data. The variables with significant amount of data that were missing, that included things like race. Age is great, outcomes are great, BMI is pretty good, but race, smoking, these things are of limited value, so I would say that limits the generalizability of those findings. Also, any other protocols besides FLAIR, agonist, and antagonist, they're not tracked by SART. So in conclusion, age, race, and markers of DOR are characteristics that predict recurrent poor cycle outcomes in IVF cycles, and this is consistent with existing IVF literature. Just repeating the second cycle improves outcomes. We saw that 75% of the patients were not canceled for a second cycle. And overall, there seems to be some benefit in changing the protocol after a cancellation. But future studies are needed to assess whether more contemporary protocols, specifically patients with a prior cancellation indication, are needed. And I'd like to acknowledge SART and all the work they do to compile this data, and really, allows us to try and understand how we practice and how it impacts our patients and the way on a population level. And without the efforts of SART, this research would not have been possible. And these are our references. Thank you.